Thank you so much to the organizers for having me here. I apologize for being the last speaker. Try to get through my talk as fast as I can. But today I'm here to talk about a project that we're doing in Dhaka, Bangladesh. And what we're doing is environmental surveillance for SARS-CoV-2 and other pathogens. And it's for public health impact. It's a highly collaborative research with the government partners of Institute of Epidemiology and Disease Control Research, University of Virginia, Imperial College London, and ICDDRB, which stands for International Center for Diarrheal Disease Research. And here you can see a typical wastewater site that we surveillance. And here are some of our field workers and some of the people from my lab doing some field work. Just a quick background on what's going on in terms of COVID-19 in Bangladesh. We are the second most affected country in South Asia after India. There's been about 2 million cases reported in Bangladesh compared to 44 million in India. And in terms of cases per million population, it's about 3 to 5 times lower. And what we do know from other data is that there's a lot of undercounting of cases in Bangladesh. And this was a lot to do with the fact that they were charging for testing, which made it impossible for a lot of the people who were poor to get tested. And in terms of vaccination, it started in early 2021, and as of now, people have had about 73% of the people have had at least 2 doses of the vaccine. So some of the research questions that we wanted to ask is, can the detection of SARS-CoV-2 in sewage somehow provide an early warning of changes in transmission level in the city? And also, how variable is the sewage detection depending on the different locations compared to the reported clinical cases? And lastly, we wanted to see if genetic sequencing of the sewage can provide an understanding of emergence and spread of the VOCs. So this is one of the reasons why it's so challenged to do this type of work in Dhaka is that most of the sewage network is made up of informal sewage, meaning most of it all ends up back in the river without it ever being treated at a wastewater plant. And so one of the first activities that we undertook is trying to understand this informal sewage network. And what we did was an activity called blue line tracing, which is actually going out to the field to actually draw each one of these informal lines, including the ditches that run right in front of these homes. And then, trying to digitize these informal sewage network with the larger, more formal sewage network that existed in Dhaka. And so Ohidul Islam pictured here, his job was, once our team members went out to the field, came back with these traces on a physical map, he spent the night pretty much digitizing all of these lines and then connecting them. And once that activity was done, you can see here, the dark green lines are all the informal plus the formal sewage lines that are now interconnected. And once that was done, we contacted a company called Novelty, and they created these interactive maps, and these are publicly actually accessible to anyone in the world. So this is a typical map, and what it does is you're allowed to, then this will allow you to drop a pin. Here's one environmental site, and you can see that it actually estimates the population that it captures, as well as it highlights the actual area that it's draining and sampling from. And so we were actually all set up doing environmental surveillance actually for polio and other diseases since June 2019. And we had 12 sites, which are located right here. And this was the middle income area of Dhaka. And then once the pandemic hit, we started to look for SARS-CoV-2, and we found it for the first time in the second week of March, about a week prior to the first death of someone in Dhaka from COVID. And so once that happened, we then expanded our sites to 33 sites. And then currently, we actually have 51 sites. So This is the middle income, low income, high income, and then this is a mixed low to high income. And it was really important for us to have this variation in socioeconomic status to see if there's a different level of disease transmission depending on socioeconomic status. And so in terms of the ward populations, wards are like these colored regions. The population varied from 50,000 to 150,000, and each of our catchments that are pictured here in dots captured anywhere from 1,000 people to about 600,000 people. And it was important for us to have this spectrum because we wanted to try to see if we can do some analysis to see, in terms of like, what is the sweet spot? How many people should we sample to have this dynamic range of data in terms of sewage viral load. And so these are like pictures of the typical places where we get our samples. You can see there's a lot of these just like open canals. And then there are some larger wastewater outlets, and then there are also manholes. So we work with the Dhaka Water and Sewage Authority actually to walk the city to understand like at what points these, what points were best to sample from. And so this is probably not a lot of interest to all of you out there, but this is sort of like a slide that summarizes what we do in terms of collection to detection. So for the first half of our study, we used something called a bag-mediated filtration system, and here's the bag right here. And it's dunked into the sewage, and then you grab a 6-liter sample, and it costs about $138. And what you do is once you have the sewage, you hang it up, and it goes through these ViroCap housing filters, and the filter actually captures the virus. And then, so this was what we were doing when we only had 12 to 33 sites. And once we started to hit, 51 sites, we realized it was really hard to go around town with these 6-liter bagfuls of sewage. So we switched to a new method called the nanotrap magnetic virus particle method, where we do 40 ml grab samples, and it's only about $15 per sample, so a lot cheaper. And in terms of the detection assays, we use the CDC's N1, N2 gene, just a real-time PCR assay on this Biorad Opus. We also did Illumina sequencing for VOCs and variants of interest on the MySeq and the NextSeq. We also developed some VOC real-time assays, which we ran on these Biorad PCR machines. And we also wanted to get to the absolute quantitation of how much virus is in the sample. And we did that by using a digital PCR. And then lastly, we used the TAC-BAN array assay in order to interrogate about 40 to 50 pathogens in one go using this ABI via 7 TAC platform. So now that we were able to generate a whole bunch of data, we needed a way to like somehow, illustrate our data in a tangible and digestible way to the public health officials. So what we did was I worked with very talented 4th-year biomedical engineering students from UVA. And during the COVID lockdown, they really couldn't do a lot. So they sat at home and actually developed this like nice dashboard, which is actually used by the government of Bangladesh. And it's actually, you can get to our dashboard at their government site. But our first face that you see out here is that, you see like the general trends in clinical cases and then the general trends in sewage, and then you can see each one of these wards are colored depending on how many cases there were allocated to that ward that week. And then you can see our environmental sites are shaded depending on whether you have, whether you have 0, low, medium, or high. So at this point right here, I think it's a medium viral load. And actually, if you go through our dashboard, you can actually even get information on each individual environmental site. And so this slide actually just summarizes like the collapse data across the whole city, across all 51 sites. And what you see here is the ES data is shown in purple. And then the COVID cases are shown, COVID cases that are geolocated to our study area is shown in blue. And what you can see that it mostly overlaps, especially towards, past this point here. You can see that clinical cases and environmental surveillance data overlaps some. And then you see that there's a little bit of a not so much concordance around an earlier time points where the COVID clinical cases were really hard to come by in Dhaka. There was just not enough cases, and some of these COVID cases we were able to, use mobile data and such in order to build these cases, and these were not just straightforward like real-time PCR testing of clinical cases. And so what we do see though is during major rises of these peaks, you do see that wastewater will give you at least a week or two in advance warning where the wastewater starts to go up before the clinical cases. But the highest cross correlation when we looked at it really in terms of each individual ward was that the clinical cases, usually the sewage data precedes the clinical cases by about 5 days. So you're able to get an early warning of about 5 days. And so another thing that we worked on is Stephanie Brandhofer, she's a senior data analyst on my team, worked on developing a Varma model to do some prediction modeling. And so the Varma model uses both the sewage and the clinical data from the previous 2 weeks to try to predict your cases for the following week. And what you see here is that it did a pretty good job actually tracking the disease. And there are places like here where you see that the model and the actual what happened actually, does not coincide very well. But that has a lot to do with Eid. There's a lot of movement of people from Dhaka to the rural areas, and that actually offsets the clinical cases in Dhaka. So this is just looking at 2 weeks of prior data of clinical cases in sewage, and it predicts 1 week in advance. Yeah, and it's actually something that we incorporated into the dashboard. And so the government looks at it to see, are we going to see a rise in this area? And if it's an area where they don't have a lot of clinical cases, they would set up these booths to do some testing actually out in the public. So this is our data actually broken down more on each individual environmental site. And I just want to remind you again, this wards 2, 3, and 5 are low income, 8, 9, and 10 are middle income, and then 18 and 19 are the high income area. And I think what you notice right away is this very high caseload in the high income area. And this has a lot to do, once again, due to the fact that people could actually afford to get tested. And so, this actually will, if you just looked at the clinical cases alone, you would think, oh my goodness, in the high income area, there's a lot of COVID. But if you really looked in sewage, and you can see that the level of the viral transmission is actually pretty close. So, we haven't worked on that, but that's something that the government would like for us to work on to predict from the environmental surveillance data, if we can predict how much cases should have been there. And so we're working on that. Right. Yeah. And so again, this is the same data, but we collapsed it down to just the low income wards data together, middle income and the high income area. And once again, if you look across cases, you see that there's a lot more cases in the high income area. And you can see that the population is actually the highest in the low income, middle income, and high income. And what you see in sewage, if you look closely here, is that it's more associated with the population size. So you get more burden of virus found in sewage that's associated with the population and not associated with the actual clinical cases, which is what we would expect. And despite the high amount of cases, the sewage detection of virus is actually the lowest in the high income area, where we only have 184,000 people. And so in terms of where we are now, we are definitely, like the rest of the world, really fatigued. Nobody's getting tested. So there's very little testing that's going on, but there's still a lot of virus detected in sewage, which usually indicates that there's definitely cases out there that's being underreported. And halfway through our study, we realized, okay, that's fine. We can track disease and we can sort of tell the trend, but what's going on in terms of VOC? What is driving that increase and decrease in the epi modeling? And so we decided to do some sequencing in wastewater. What you see up here is the nationwide clinical sequencing project that was going on in Bangladesh. And what we did was we extracted just the Dhaka district data, and then we did some sequencing on the Dhaka sewage. And what we saw was this nice correlation of, representation in sewage of the type of the VOC that was driving that particular, rise in cases and so forth. And what's really interesting in sewage is that you see tons of recombinants, which you don't see in clinical cases. And most of this work was led by Suporn Fulwat from my university, Tanima Rahman, and Tanya Ferdosi from ICDDRB. And we also work with Joshua Levy at the Scripps Institute, and he wrote this Freya program, which actually is being used worldwide to do some of the VOC analysis for wastewater. So another thing that's been really important for us is working with the government public health stakeholders. So we've been, from the beginning, we've been engaged with the Institute of Epidemiology and Disease Control Research, also the Health Ministry and the Dhaka Water and Sewage Authority, the local governments, it's the Dhaka North City Corporation, Dhaka South City Corporation, Department of Public Health Engineering, and the funders. And on a weekly basis, I actually write a report to the government, to the Prime Minister's COVID task force, and that's reviewed, and they look at our dashboard. And so we've been part of the mitigation effort for the COVID pandemic. And so just to wrap things up, we were able to do this real-time environmental surveillance in multiple areas of Dhaka City. And we do believe that environmental surveillance, if done carefully, can actually give you an early warning of increases in transmission. And variants of concerns can be, in fact, tracked in sewage. And it's really nice to have something like a dashboard to share with the public officials so they understand the data that you're getting from the laboratory. And for the future, what we're trying to do is this multiple pathogen approach. Now that we got going with SARS-CoV-2, can we do more? And so just a little bit of taste of what we've been doing, at least for the prior work, is we were looking for about 40 different pathogen sewage. This is actually data from one of the studies that I did that's a clinical study. So we saw seasonality of different pathogens, and we also saw seasonality of those pathogens also in sewage. And unfortunately, the data does not come from the same time point. So we've actually, we were able to get additional funding to do this work, this type of work where we do both clinical and environmental surveillance. And we're doing that in Karachi, Pakistan, as well as in Bangladesh. And what we try to do is we first look for cross correlations to understand, can any of these sewage detections give you a warning of upticks in clinical cases? And sort of just on the side, we do use other modeling approaches to try to understand our data. For example, Jillian Gold from Bill and Melinda Gates Foundation has been helping us to look at our data from Karachi, and it's very interesting. She ran a GAM model, And the question she was trying to ask is the detection of the pathogens actually associated with something other than a real detection of the pathogens? And what she did find in Karachi was that there is this association taking account of all the pathogens. There is this trend up and down of detection. You can see that periodicity here. And so our next question was, what is causing this? And does this correlate with any other weather phenomena and so forth? So it's been really interesting to use some of these modeling tools to try to understand our data. So I'm probably not going to go into too much here, but again, using those trends that we saw earlier, you can see that yes, the two SARS-CoV-2 targets track each other, but then we find this weird thing where sample virus actually tracks right along with SARS-CoV-2, and we know that that's probably not a real epidemiology phenomena, so now we need to go into our data to figure out why this is going on. But anyway, I have a lot of people to thank, but these are the people on my team. Dr. Isabel Blake from Imperial College London. She is a phenomenal epidemiology modeler who actually models poliovirus actually for WHO and Bill and Melinda Gates Foundation. These are the people in my lab. And then my team in Bangladesh. And also a lot other people to thank, but thank you so much.
Yeah, very nice talk.
Thank you.
Looks like clearly there is a strong signal embedded in it, in terms of early warning from.
Yes.
And what's amazing is that relatively few sites were enough. Did you do a study to see, and this you can do probably if you have the data collected, to find minimal number of sites that you would need to get the signal right? Because eventually, back to Cherry's question for all of us, Chitra, we want to try and minimize the amount of resources needed to do detection.
Yes.
And it looks like 50 was enough, at least from the way you were doing it. So could you shed some light on it?
Yeah, so we started probably with 114 sites and really tried to get rid of sites that were not informative. And I think we hit the sweet spot with about 51. And I think you can further reduce that. I really believe that from each section, if you had one or two good ones, that's going to tell you enough about the disease trends. And so you could probably get away with having maybe 12 instead of 51, at least for SARS-CoV-2. That's a pandemic. But if you're looking for something like cholera, which is very geo-specific, that in that case, you're going to want to have tons of different sites across your study area so that you can geolocate where that cholera pandemic is occurring. So I think it depends on the disease that you're looking at, about how many samples you want to take and where you want to take your samples from. So. Yeah, so we're doing that analysis right now, trying to understand for polio, how many sites should we have? Or for SARS-CoV-2, how many sites are really necessary to understand the disease? And then again, for cholera, it's going to take it takes multiple years because the cholera the cholera outbreak happens sporadically and it's in different areas of Dhaka. And so we're hoping to have, we have so far about 3 years of data. We're hoping to build that to 5 years to take a look at that. Thanks. Yes.
So you said that you had a 5-day kind of, you could predict 5 days in advance from this. And 5 days is roughly the incubation period of the Wuhan variant. So for Omicron, I think the general consensus is that the incubation period is 2 or 3 days. So do you see that in your data at all? Or?
Oh, that's very interesting. Yeah, I think that would be a great analysis to do 6 months and then cover a peak that's like the initial Wuhan peak, the Delta peak, to see if the 5-day changes depending on each individual variant. We have not done that
It
analysis.
sounds
That's a
like it
great
should depend on
suggestion.
incubation, right?
Yeah, that's a great suggestion. Thank you.
Is there some information on the degradation of the wastewater? The dynamics of how it degrades, because that might be an important factor in estimating the infection levels, the viral load, and so on.
It is. I agree. And I think for this particular pandemic, though, just because there's a sheer amount of volume of people pooping into the system, that there's just not that much degradation. And so even if there is degradation, there's still a lot of RNA available for us to be able to detect this up and down. But as the pandemic dies off, and we have to take in more the account of degradation and its association with the signal, I think we haven't gotten there yet. Because most of the time, the wastewater is always positive for SARS-CoV-2. On a very rare occasion, recently, we've seen maybe 5 or 6 sites that are at 0.
Thank you.
Is there a question?
Okay.
So my question has to do with the load of the virus itself. And I think the reason I asked my first question is this conundrum. When you have very little signal and this disease is just starting, you intuitively need much bigger sampling place because you don't know where it's going to start. Once it reaches a certain amount of density, if I would call, or prevalence, then a fewer set of sites are possibly enough.
I agree.
And so this is a very counterpoint, because you have to keep sampling a lot when disease is not there, with the hope that you'll
Right.
catch it when it first comes in.
I mean, we were able to catch the first start, the takeoff, with just 12 sites in Dhaka.
That could have meant that there's already enough in the population, you think, or?
Yeah, I do. I think the thing to keep in mind is that, if you can get a good wastewater surveillance, there's no need to test a whole bunch of people, because you're essentially having one site. If you're sampling, 12,000 people, that's like getting, signal for those 12,000 people. And so it is still, even though, might not be cheap, it's still very cost effective compared to rolling out a huge, zero prevalence surveillance or, clinical surveillance.
If I may ask one question. So when you are talking about environmental surveillance, this is predominantly everything related to sewage. Are there any other thing that is in practice? Like I would imagine for office spaces or universities which have a central air conditioning or an HVAC, is it practical to think of a surveillance based on the air that is being recycled?
Yeah, so I have friends who did hospital air quality surveillance for SARS-CoV-2. And that was very interesting, but it's really, really difficult through air to get this, what is it called? This type of dynamic up and down that you see in the wastewater. You see a pretty low level signal in terms of SARS-CoV-2, like when you do air filter surveillance. It's quite difficult. But there are all types of other surveillances that we do other than wastewater for other diseases. For example, I have a household Campylobacter transmission study where we actually look at animals and other environmental samples. And so, but your suggestion of doing buildings is wonderful. I think many institutes did that, where they knew the amount of people that's inside a building, and then they did the sewage surveillance, and they knew how many people were sick inside. And so then you can build a better model to understand that, that little signal here correlates to 5 people being sick within a building and so forth. So.
Thank you. If there are no further questions, let's thank Professor Mami Taniuchi once more.